dextrose or 2.5% dextrose. And we would add it as part of our maintenance fluid. Okay? And here again, it's too difficult to photograph, but essentially I've put down a slide with changes in heart rates according to age, blood pressure, and temperature targets as well. Okay? There are also quite a few helpful apps and online resources for you to be able to input just the patient's age and weight, and it will immediately calculate for you all the drug doses you might need in an emergency situation. I at least have about 3 apps on my phone, which even and I've been doing pediatric resuscitation now for 16 years. I still age and weight input them because I don't want to make mistakes. Okay? We're human. We're not super. Okay. Okay. One word on intraosseous access. If 2 attempts at intravenous cannulation fail, then you have to start considering intraosseous access. And in kids, the 3 sites that we use are the proximal tibia, the distal tibia, and the distal femur. Okay? You always check femoral pulses in infants and younger children, and either femoral or cardiac as the kid grows older. Okay? A weak central pulse could indicate decompensated shock, whereas a thready pulse in the periphery could just be the initial sign of shock. But if the pulse is weak centrally, then you're in a lot of trouble. Okay? And if no pulse can be felt, or a bradycardia of less than 60 beats per minute, that is a trigger to start CPR. It is not just the absence of a pulse, but bradycardia less than 60 in kids. Okay? Okay, we've gone over the algorithm yesterday. There are a few major differences in the CPR algorithm between kids and grown-ups, but essentially, once we've confirmed that there is no sign of life, we start CPR with 2 breaths to 15 compressions, minimizing interruptions. We attach a defibrillator or monitor, and right now, our wet flag calculation of energy joules will come in very handy, that we did it at the beginning and not now in an emergency. And we're going to assess the rhythm, whether it is a shockable or non-shockable rhythm. The 2 shockable rhythms are VF, which is essentially a child with a marker and drawing a squiggly line, and VT, which is a regular white complex tachycardia with no pulse. Those are the 2 shockable rhythms. Everything else that has no pulse is non-shockable. Okay? So if it is a shockable rhythm, you deliver a shock of 4 joules per kilo, and you continue CPR at 15:2 for another 2 minutes. If it's non-shockable, do not give a shock, and you continue CPR. Okay? One word on the drugs. If it's shockable, you give adrenaline at 10 micrograms per kilo, which we've already calculated on our previous slide, after the second shock. If it is a non-shockable, you give adrenaline immediately the moment you diagnose a non-shockable rhythm. And in children, the vast majority of CPRs are usually non-shockable, because usually it is a result of some form of respiratory hypoxic issue. Okay? And as always, during those 2 minutes, you consider your 4 H's and your 4 T's, things that might have caused the cardiac arrest. Okay? So our 4 H's are hypoxia, which we're dealing with because we'll be giving the patient oxygen. Hypovolemia, we'll be resuscitating with fluids. Hyperkalemia, so a venous gas will give us an indication whether the child is hyperkalemic, and we would give a hyperkalemic regimen, or whether the child is hypo or hyperthermic, and do we need to do something about the temperature. The 4 T's, tension pneumothorax, so is there air in between the lung and the chest wall and causing no cardiac output? Is there tamponade? Has the child imbibed some form of poison for which you need a history? And thrombosis. As I said, the likeliest problem in children is hypoxia. Okay? Okay? And as I said, there are many charts like this that can help you with calculating your wet flag immediately on admission of a sick child. And I would always encourage, I've seen it already in emergency, having the pediatric CPR algorithm readily available for anyone to use in any acute medical setting. Okay? So we've covered A, B, and C, and now we're going to evaluate D. You can obviously use the Blantyre Coma Scale, which is specific to pediatrics, or the Glasgow Coma Scale, giving a score of 4 for your best eye response, a verbal response score of 1 to 5, and a motor response of 1 to 6. I find it quite complicated to do, so I always go for AVPU. Okay? AVPU is the child alert, is the child responding to my voice, is the child responding to pain, is the child unresponsive. So AVPU. Okay? And apart from level of consciousness, we're going to be checking other things in a child that is presenting with a disability issue. We check for signs of head injury. We examine the pupils. Are they equally reactive to light? Are they equal in size? Are there any lateralizing signs? Is the child keeping one arm immobile? Have drugs been given, either at home or by medical professionals? Are the fontanelles, if they can still be palpated, tense, a sign of raised intracranial pressure? Are there problems with electrolytes? Is the sodium low, causing a drop in consciousness? Has the child had a fit on its way to hospital, and the child has a low level of consciousness because they are post-ictal? And, I will say it again, is the child hypoglycemic? Okay? So, seizures are not infrequent in the pediatric population, but surgical pathologies happen as well. Okay? So, always bear in mind that you should always have readily available hypertonic saline to treat acute hyponatremia, which is causing seizures. And I always use the 3-3-3-30 rule. It's 3 mils of 3% sodium over 30 minutes. Okay? And aiming to raise the level of sodium by 3 millimoles. Okay? And always bear in mind that you should always have sedation options when it comes to pediatrics, things like morphine and chloral hydrate, depending on the child's age. And again, I consider that's why the M&Ms are there. Never forget that hypoglycemia is a leading cause of drop in consciousness in children. And it's a pinprick away. Okay? Okay, move on to the final part of our evaluation, which is E, exposure. Proper exposure, but keeping the child warm is a priority. So temperature management. Are there any rashes? Are they elevated? Are they blanching? Are they non-blanching? Are they purpuric? Are they hemorrhagic? Are there any broken bones and limbs? Are there any bruises, burns, wounds, scars from previous surgeries? You will discover nothing of this if you do not expose the child and then cover them up again. Okay? Okay. Now, one final note before we proceed is that by this time, you've evaluated that the child is critically unwell. The one thing you should never be doing in a situation like this is working alone. Okay? You immediately call for help, more senior colleagues, the more the better. Everyone's opinion is important, and all people are not always forthcoming with the truth. So I find many times in pediatric practice that sometimes the story changes as time goes by. So human nature is what it is. You always keep a high index of suspicion, and that's why we've been called as healthcare professionals, because our interest is that of our patient above everything and everyone else. Okay? And I want you to take away this point. Okay? So our interest is always the patient. The patient is always the most important person in the room. Okay? Okay. Now, this is an ABCDE, a primary survey. Obviously, once you go for a secondary survey, this becomes more focused on advanced life support, interventions and management, and finding out more what the cause of the problem is. Okay? As we said, just because you've done your ABCDE once doesn't mean you stop. You have to keep on reassessing, you keep on reevaluating, because your treatment could work, your treatment might not, patients might improve, patients might deteriorate. Okay? And I think that's it for the start. So in summary, what we did today was the first part, we covered a few important anatomical and physiological differences between kids and grown-ups. We've established that it is very important to be prepared. So when a child is coming in, immediately try to calculate a wet flag to gain as much information about the child as possible. We went over some clinical scenarios showing problems in each part of our individual assessment. We discussed an ABCDE approach as our primary survey. And we've also established two important golden rules, that children are not small adults, and a child will keep on compensating until they don't. Okay? Thank you. I am open to questions. And after all that talking, there must be a question or two, even from the online forum. Thank you. Guys, remember we are online.
Okay, thanks for the presentation. Can you please go over the 3-3-3-30 rule?
The what, sorry?
3-3-3-30.
Okay, so when it comes to treating hyponatremia that is causing seizure activity, something in the region like a sodium of a 115, our protocol is usually trying to raise it by 3 millimoles, always maximum of 10 millimoles within 24 hours because of central pontine myelinolysis. But our protocol is 3 mils of 3% sodium chloride over 30 minutes by 3 millimoles. Okay. We can discuss it further. There are many protocols. This just happens to be the one that we use. Okay. Anyone else? Sorry, I'm hard of hearing, so I have to come close.
Yeah, my question is a little bit controversial. If vitals are unrecordable in a patient, will you still give that adrenaline because
if the vitals are unrecorded? Depends on what vital is unrecorded, because
BP,
BP, etc.,
saturation?
So, if I am suspecting cardiac arrest and I've confirmed it with an absence of a pulse or a bradycardia less than 60, then that means starting CPR. And then I would follow the algorithm depending on what rhythm I would find on the defibrillator pads. So if it is a shockable rhythm, I would give adrenaline after the second shock. If it's a non-shockable, I would give adrenaline immediately. Well, then no controversy there. Easy answer. Anyone else? Okay, thank you. I don't know what time it is. We will take a 10-minute break, guys, okay? And we will start at 9:50. I can turn this off for now, yes? Okay, guys, we'll be starting in a couple of minutes. Okay. Okay. So if we could remove that from the side. So good morning, everyone. Again, thank you for joining us even from the second talk we have prepared today is a bit more focused on respiratory failure in the sick child. Okay, and I plan it's shorter than the previous presentation, but it will focus on three important points. We will look a little bit at what respiratory failure is. We will revise what we've talked about when it comes to recognizing and assessing the deteriorating respiratory pediatric patient. And the most important bit we will be talking about is I will be introducing a very safe, effective, and easy tool to use, which is high flow nasal oxygen. Okay, it is a form of non-invasive ventilatory support that can be used as a bridge between an oxygen mask, which provides you with no ventilatory support at all, and intubation, which is the extreme. Okay? So we start a bit by defining respiratory failure. So rest failure is a clinical condition lungs fail to change gases, which means there's a problem with oxygenation, oxygen going in. There's a problem with ventilation, CO2 going out, or the two of them happening at the same time. Okay? There are different types of respiratory failure. We start with type 1, which is hypoxic failure. It occurs when the PaO2 falls below a certain level and the PaCO2 remains lower than normal or remains normal. In this type, the gas exchange is impaired at the level of the alveolus. One respiratory failure would be conditions like ARDS or pneumonia. We move on to type 2. In type 2 respiratory failure, the CO2 is higher than 45. So as opposed to this being a hypoxic problem, like in type 1, we have a hypercapnic problem that is type 2. Okay? Hypoxemia isn't, and this happens because there's a problem with just oxygenation. Okay? It's usually caused by obstructive problems like worsening asthma, chest and post-operative lung collapse, some form of obstruction. Okay? The underlying mechanisms, we won't waste too much time on this. One of them is hypoventilation. When the PaO2 and the oxygen gradient are normal and the PaCO2 is elevated, this is a problem of hypoventilation. Things like sleep apnea, drugs that depress the CNS, these can cause problems of hypoventilation. And more importantly, a VQ mismatch, where you either have part of the lung that is ventilated but not perfused with blood, okay, which is called alveolar dead space, or where you have a part of the lung that is perfused with blood but has no oxygen, and that is shunt, because that blood will not get oxygen because there is no oxygen to be given. Okay? Something about causes, and I've divided them into the neonatal and the pediatric population. So in neonates, the causes of respiratory failure are quite a few. You have the transient tachypnea of the newborn, some form of laryngotracheobronchomalacia at birth, obviously congenital heart disease, and that is a lecture in and of itself, dividing them into the various subtypes. Neuromuscular or skeletal disorders, meconium, aspiration, and decreased level of consciousness due to some form of metabolic pathology. Okay? Moving on to respiratory failure in pediatrics, here they become a little bit more diverse. We have bronchiolitis, which is a leading cause of problems in the age between 5 months and a year, year and a half. pneumonia, croup, asthma, anaphylaxis, aspiration, an inhaled foreign body, and a neuromuscular disorder. These are only to name a few. There are many more causes of respiratory failure in the pediatric population, but I mentioned here the commonest ones. Okay? Now, this is something we've already covered in the first lecture, but it is so important that I believe it's worth repetition. Okay? The differences between the pediatric and adult population and why a pediatric child is more prone to respiratory failure in certain circumstances. Their large head with a prominent occiput, so they tend to obstruct when you hyperextend the neck. Their long, narrow, omega-shaped epiglottis, which is harder to channel whilst you're intubating and is prone to inflammation. The conical rather than cylindrical airway, which means that a microcuff or an uncuffed tube have to be used, depending on the size, of course. The smaller internal tracheal diameter, which means that even a small secretion, small amount of blood, small foreign body can cause a dramatic increase in airway compromise and obstruction. Okay? The chest wall is more compliant, so it's really soft, and the abdomen is weaker, so the child is more prone to fatigue, as we've covered in the previous lecture. Okay? Breathing, the small diameter is not only in the trachea, but persists all throughout the tracheal tree. So, as we said, a change in diameter leads to a much bigger change in respiratory flow, and also the higher respiratory rate and the fact that the infant ribs lie more horizontal and they rely on the diaphragm for breathing. So if there is any problem in the stomach or in the abdomen, then you have a problem with your breathing as well. Okay? We've covered this. The respiratory rate changes as the child gets older, and we have to bear in mind that children's respiratory rates are much faster than those of adults. And also we mentioned that the FRC, which is the amount of oxygen we survive on, is enroached on, at least in the first year of life, by the closing capacity, which means that when lying flat or when intubated, children tend to collapse their lungs more. Okay? Now, again, a bit of revision on what we covered previously. How are we going to assess that the child has an increased work of breathing problem? So before we go into this, remember we said that respiratory failure is either a problem with oxygenation, a problem with ventilation, or both together. Oxygenation is cured by delivering oxygen. Work of breathing is fixed by providing respiratory support. And I say this because of the high flow nasal oxygen I will be introducing later. Okay? How do we assess worsening work of breathing? Okay? We assess the body position, visible movements of the chest and abdomen, and the breathing pattern. Are there abnormal airway sounds? Is there stridor? Is there grunting? Is there wheezing? Visual signs of increased work of breathing. Is he triboting? Is there retraction intercostal spaces? Tracheal tug, flaring of the nares, head bobbing, gasping. Is the child getting tired? Is the effort now going down, not up? Drooling, and all of this reflects the airway, oxygenation, and ventilation. Okay? And we're going to give a clinical case again. So we have a 10-year-old boy admitted to the emergency department because of increased work of breathing, shortness of breath, and a cough worsening over the past 3 days. Okay? And what are we going to do when we're going to assess this child? We're going to use our ABCDE approach. Okay? The airway is patent. The child is speaking in short sentences, but there are no added sounds. Okay? The breathing rate is elevated. It's 30 breaths per minute. On auscultation, there are crackles in the right base. Sats of 88 on room air, which go up to 96 on non-rebreather masks. But there's also accessory muscle use Noted. So there's a problem with oxygenation and a problem with work of breathing. Okay, so there are two problems here. Okay. Incidentally, any suspicion on what might be going on with this history and this presentation? Any suggestions what it might be? Perfect. I agree. It looks like a community-acquired pneumonia. Based on the history, his disease progression, the cough, etc., the findings on auscultation, and the fact that there's an oxygenation and work of breathing issue. Okay? What would you do? We know that definitely we've already started doing something by administering oxygen, but before coming up with a definitive plan, we have to continue our assessment. Okay? Slightly elevated. There's no fever yet and no rash. Actually, that should be a mistake. There should be a fever there. Sorry, guys, my mistake. Let's say it's a fever of 38. In keeping with the pathology, the child is upset but consolable, and the CO2 and capillary gas of 42 millimeters of mercury. So higher end of normal. Okay. Our plan, we're going to obtain vascular access, fluid maintenance and resuscitation as needed, antibiotics, strict parameter charting. We consider steroids, cultures, and investigation, and definitive oxygen therapy. Okay? Now, be it a non-rebreather mask, a normal Hudson mask, a Venturi mask, provides oxygen, but provides no assistance for work of breathing. Because for work of breathing, you need assisted ventilation, which is where I'm going to introduce the concept of high flow nasal cannula. It is not something you have here locally. I was discussing with Adoma, but it's in the pipeline. So essentially, this is what high flow oxygen looks like. And looking at it at face value, you will think, oh, it's a nasal cannula. Nothing special about it, right? But it is a special nasal cannula which has a much higher diameter attached to a turbine, a mixing device, and a heater, a humidified heater. So this device provides oxygen, very high flows, we're talking 30, 40, 50, 60, 70 liters per minute, changing oxygen concentration from 21 to 100. So as we said that there are two problems going on, an oxygenation and the ventilation problem, work of breathing, this device provides you with two initial, because it's not always enough, initial supports for that, titrating oxygen and titrating the work of breathing with the flow that will provide some pressure. And the high flow rates are there for this specific reason. So when I'm sick, right now I'm breathing normally, and the speed at my lips is very low, 10 liters per minute. But when I breathe very fast, I'm breathing initially something as 50, 60 liters, but the speed is very high. So if I'm given a normal face mask, I'm not only sucking up the oxygen from the face mask, but I'm also entraining air from around me. So in fact, I'm diluting the oxygen I'm getting and working harder for it. Okay? Because we're giving the oxygen at such a high flow, that high flow rate starts overcoming the initial work of breathing. So in many instances, high flow has been a perfect bridge, stopping kids from requiring intubation. Okay? So these are all taken from a protocol we've written for our university hospital. So high flow delivers humidified and heated oxygen than the patient's inspiratory flow. It acts as a bridge between low flow oxygen, face mask, nasal cannula, etc., and continuous positive airway pressure, and has been proven to reduce the need for invasive ventilation and intubation. It is an extremely safe device to use. It has several benefits. We are delivering oxygen at a precise percentage. It decreases the respiratory rate. In fact, when we start kids on high flow in our pediatric course, the first thing we realize over the first hour that the respiratory rate slows down. Not because they're getting tired, because they have to work less hard for their oxygen. The high flow rates deliver a little bit of positive end expiratory pressure, some PEEP. PEEP is the pressure that keeps your lungs open at end inspiration. And when you are sick, you need more PEEP to keep your lungs inflated. And the flow rates we use, 50, 60, 70 liters per minute, provide a certain amount of PEEP. They increase the tidal volume, they enhance the FRC, which was mentioned multiple times, and we wash out the physiological dead space. So we start oxygenating parts of the lung that actually need the oxygen. Okay? This is what it looks like. There are various sizes for pediatrics. I'll tell you something about how we size them. They come on a stand. It's a very simple device because the only things you need to change are two things: how much oxygen and how much flow rate. And I'll give you an example. You are all students and working in pediatrics, correct? Yes. There aren't any surgeons around. No. So to give you an example of how easy it is to use, in my hospital, we've taught the surgeons how to use it. Okay? So the surgeons know that if they have a respiratory failure on surgical age high dependency, they will start, if the oxygen mask is not enough, by adding, I hope there are no surgeons online. They will kill me. I admit, all my best friends are surgeons. And when I said this to them, I got into a lot of trouble. But my point is, do not be afraid of this device. It is extremely easy to use, and the benefits we've seen on our pediatric population has been immense. Okay? So it comes with an air blender, and the thing at the top is a humidified bath. So the air being provided is humidified and heated. Because if you provide cold, dry air or oxygen to your patients, you dry up all their mucosa and you run into all sorts of trouble. Okay? So what are the indications? Any child with increased signs of work of breathing and or increased oxygen requirements. And these would be typical examples of when we would start it. A child who has been recently extubated and needs some support before transitioning to a normal mask. Pneumonic processes, hypopnea, OSA, asthma, bronchiolitis. We've used high flow nasal oxygen in all of these situations with success. Okay, there are a few contraindications. Generally speaking, there are quite a few listed, but you can divide them into three things. If there is a foreign body, because the high flow will push the foreign body further down. If there is something wrong with the face, because remember, you'll be applying cannula to the patient's nose. So if there's a problem with a fracture, bleeding, some form of burn on the face, it might be a problem to apply the nasal cannula. And also problems with pneumothorax, again, because the high flow can increase a pneumothorax that is not treated. Okay? We also proceed in caution in reduced level of consciousness, purely because, not because the high flow will cause problems itself, but because this device requires a cooperative patient, at least a patient who is alert. Because if the patient is getting tired already, we've probably missed the boat when it comes to using high flow as a bridge. And we might have to proceed towards intubation. So we say level of consciousness reduced is a relative problem, is because we need a patient to cooperate with this machine. In fact, we need to tell the children to breathe through their nose, not through their mouth, which can be tricky. Okay? Complications. The most important one is abdominal distension, and they tend to split their diaphragm. That is the one big issue that this device has, because the children will swallow some of the air that is being entrained down. Okay? Mucosal injury, but if your bath is set at a good temperature, not too hot, not too cold, and kept regularly full, then this should not be a problem. Okay? And obviously, if, like all therapies, therapy can fail and you need to proceed to something else. Okay? How we start high flow therapy, at least in the centers I work in pediatrics. Okay? First of all, we have a chat with the patient and the carer, and we inform them of the therapy we are about to use, and we explain the indications and why we think it is a good therapy to try to avoid needing more advanced interventions. We take a venous or capillary blood gas and we repeat it 2 hours after starting high flow nasal cannula. We go for capillary gas because we try to look at acidosis and the level of CO2 we are dealing with. And we use CO2 as a marker of fatigability. Okay? If indicated, we perform a chest X-ray or a bedside ultrasound. I tend to prefer using ultrasound on lungs. I tend to feel it gives me more information. But obviously, a chest X-ray is the standard what we do. Okay? We attach continuous oxygen monitoring, saturations, and we start trying to select an appropriate nasal cannula, which is 50% of the diameter. So if the diameter is this big, the nasal cannula has to be half of it. Okay? Too big and it will cause discomfort, too small and it becomes useless. Okay? And then we have typical settings which we start at depending on age. If the weight is less than 10 kilos or the age is less than 1 year, we set a flow rate of 2 liters per kilo. So a 10-kilo child would get a flow rate of 20 liters. Okay? If they are more than that, we start per kilo. If there's no improvement after 15 minutes, we double that. Okay, so a child that weighs, I don't know, 12 kilos would get, first starting a flow rate of around 12, then we'll take it up to 22. Weights beyond 12, we always start at 2 liters, and the bigger they get, we can increment to 2.5 liters per kilo. The maximum flow rate in pediatrics we go for is 50, sometimes 60 liters per minute, mostly because we're limited by weight. Okay? The 70s, 80s, 90s are usually reserved for high flow in adults because, I'll make a small adult side note, we use high flow a lot in the adult population as well. And even in the adult population, it has been a godsend when it comes to avoiding the need to re-intubate someone, to give a patient a trial off the ventilator and avoiding intubation. So it's been a big help over the past 10 years. Okay. We set the initial concentration of oxygen at 40. So far, we've only set 2 things, the flow rate and the oxygen. We start at 40, aiming for SATs of 92% or more. If the SpO2 remains low after 5 minutes, we increase it to 50, and we start documenting parameters every 15 minutes. Okay? Every 15 minutes because things can deteriorate rapidly, especially in the first hour of starting any form of advanced ventilatory support. This is also true for non-invasive ventilation, for CPAP. The first hour is telling whether you persist or whether you give up and say we need to tube. Okay? After 1 hour, we review. If there are signs of clinical improvement, yay, we're happy. The heart rate and respirate will have gone down by 20%, and the work of breathing improves. A child that is able to verbalize will tell you, I am feeling better. We continue monitoring SpO2 and documenting every 2 to 4 hours, and we don't change any settings. We keep everything as is. Let's say that there are no signs of clinical improvement. Deterioration and able to maintain SATs. The flow rate is at max, and we're still getting SATs of below 92%. The one thing I would like to stress is that high flow is not a magic wand. If it's clear that it's not working, you don't fool yourself into thinking it is. You keep on doing it. You just decide, we tried it, it failed, we need to proceed to something more advanced. Okay? Something about the nursing aspect that comes with high flow It is wonderful to use for doctors and nurses, and it is also relatively easy to maintain. So the child needs to be in a semi-upright position. All kids with high flow need some form of nasogastric tube to always decompress the stomach. The nose needs to be taken particular care of, especially if there are secretions and stuff. It needs to be regularly toileted every 4 hours. Okay? Always observe that the cannula hasn't slipped. They have two small adhesive pads which you stick to the sides of the cheek, and you attach the nasal cannula to them, but it can slip out. And then if it slips out, it's useless. Okay? Charts and nose assessment daily to see if there are any scratches, any bleeding, any swelling. So we catch it early on. And we also check the bath regularly to see that it's not run out of water. Okay? Continuous oxygen monitoring and heart rate with pulse oximetry should be done every 2 to 4 hours. Flow rate and oxygen concentration and humidification should also be documented. So you don't only document the parameters of the patient, but also the parameters that you have on your ventilator, because you want to know that the child is well and stable with a flow rate of 50. If the child is well and stable with a flow rate of 30, then the child is getting better. But SATs of 98 are useless if you don't know how much oxygen you're on. Because if I take SATs right now on me, and they're 98, and someone intubated upstairs, and he has SATs of 98 on 100% oxygen, that's extremely different. Okay? The sterile water bag is replaced every 4 cannulas, every 24 hours, sorry, and the tubing has a shelf life expiry of about 7 days. Okay? Always remember that these are sick children, and sick children, what did we say? Do not eat, do not drink. So these have not only a respiratory problem, but they are also volume depleted. So any sick child with a high work of breathing, altered mental status, vomiting, apnea, respiratory rate above 70 will need IV fluids because they will be unable to tolerate anything oral. Okay? Okay? And I won't go over this, but we have plans for feeding for term infants, children, and if they are unable to swallow. The older the child gets, and if they are a little bit more stable, then we allow oral intake in small boluses, because the risk of aspiration is low, provided the children are selected appropriately. Kids with comorbidities, apneas, suspected pneumonia, and the fact that they were tolerating food before admission. If those criteria are met, then we'll allow you to eat. If not, we go for enteral nutrition and/or fluids. Okay? So a couple of days have passed on our 10-year-old boy, and he is now getting better. His work of breathing has increased. The repeat chest X-ray has shown a reduction in the pneumonic volume. He's responded to antibiotics, and we're now going to start weaning the high flow. With high flow, because it is a pressurized system, you can't just remove it. Okay? As you've built it up, you have to step it down. Okay? So weaning high flow, once patient has been clinically stable for 24 hours and has normal cardio-arrest parameters, we can start attempting weaning. So we take it down, the FiO2 is taken down by 5 to 10% every couple of hours until you reach 30%, which is slightly elevated compared to the 21% we are breathing in now. Okay? If the child becomes distressed, you immediately go back up. And maybe you start thinking, oh, he's not as stable as I thought. Okay? Once the oxygen goes down to 30, we start reducing the flow rate slowly. Okay? And if the child remains stable for 2 to 4 hours, you reduce the flow rate further. And if the child remains stable for another 2 to 4 hours, then you stop it completely. So the weaning process, if all goes well, takes about 12 to 16 hours once the child is stable, and provided we don't have to escalate it at any point. Okay? That's it. So in summary, what we covered in this lecture, we covered a few things. So we went over the definitions of respiratory failure. We talked a little bit again about why the pediatric population has certain differences as opposed to adults when it comes to breathing. We talked about the difference between oxygenation and ventilation. We went over a clinical case of a pneumonia that looked like he would benefit from high flow nasal oxygen, and we've introduced high flow as a means of providing both oxygenatory and ventilatory support to the sick pediatric population. Thank you. Questions? Okay, yes. So very, very good point. So if it is a stable asthma and you are trying to bridge the time towards the improvement of symptoms, especially if it's mostly an oxygenation problem, then high flow can be used safely. If the asthma is life-threatening, we covered this in the previous lecture, if the asthma is life-threatening, high flow will not work. So you have to evaluate whether you are dealing with stable asthma, acute asthma, acute severe asthma, or acute life-threatening asthma. And this is usually determined not only by how much oxygen you're managing to gain, but the presence of a wheeze, your work of breathing, your level of consciousness, and most importantly, if you start retaining CO2. Because if you start retaining CO2, then your ventilatory mechanism is going off. And in asthma, that is a quick spiral. And using high flow then would be wasting time. But if it is a stable patient with an oxygenation wheezy issue and the child is cooperative, then by all means, attempt high flow in that case. Does that answer your question? Yes. Okay, so it is 10:30. Good. We will take a 15-minute break, and I will be presenting my last lecture this morning, which is arterial blood gas interpretation. Okay, so it's 10:26. We start at 10:45. Okay, thank you. Close this one. Thank you. Pardon? No, then leave. I don't think we'll have time. I have to deliver it online from home. But this is more important.
The ABG interpretation, we have other class.
I don't think so, because I was meant to give you another lecture, but I am teaching till midday today, because then I'm going with Adoma to the pediatric ICU. So 12:15. Is that okay for you guys, or is it good for you, or I don't think there's anything else now. Is it good for you?
Yeah, so
Because of time, I continue now. Yes, no problem. You can go back to work. Okay. 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 Now just give me a couple of minutes to rest my voice, and we'll start. Yes, please. You can get me some water. Love. Thank you so much. Thank you.
I have a question. I want us to know the difference between CPAP, BPAP, and what is the difference?
Okay, so CPAP is continuous positive airway pressure. So it's giving pressure at 10 millimeters of mercury, irrespective of whether you're breathing in and you're breathing out. CPAP continuous. Okay?
It's about pressure.
Now, it's positive airway pressure. So you're giving a pressure of 10 centimeters of water to the patient all the time, even when they breathe out. BiPAP gives you bi-level. So you have a pressure, say, of 10 when I breathe in, and the pressure of 7 when I go out. Okay, so that's the difference between CPAP and BiPAP. And then an invasive mode of ventilation and your PEEP, but that's quite advanced. Okay?
Please, can we have a break?
Yes, okay, okay. Oh, shall we start now? Now I understand. Oh, thank you. A bottle of water will do. I think there was one around the corner, I believe. There it is. This is perfect. Thank you. Phew. Do you think they're useful? You're enjoying them? Good. Thank you. Thank you. I try to keep them because